নমস্কার, গুড মর্নিং আমেরিকা এবং গুড ইভিনিং ইন্ডিয়া। আর বাকি সবাই যেখানে আছে সবাইকে হ্যালো জানালাম। এবিএস নিউজ ডেস্ক চ্যানেল থেকে আমি সায়ন। আজকে আমরা একটু অন্যভাবে শুরু করছি। একটু আমাদের অতিথিকে আমরা ডাকবো, তার আগে আমরা একটু নিজেদেরকে আলাপ করে নিই। সো এবিএস অফিসিয়াল ডেস্ক নিউজ চ্যানেলের কর্ণধার অরিজিৎ বাসু, উনি এই শোটা অনেক দিন ধরে করছেন এবং ওনার সম্পর্কে আমি এই কিছু বলার জন্য আমার এটা মনে হয়েছে যে এই শোতে আমি একটু ইন্ট্রোডিউস করি ওনাকে। সো অরিজিৎ বাসু উনি সেন্ট জুডস হসপিটালে ক্লিনিক্যাল ডেটা অ্যানালিস্ট এবং সেন্ট জুডস চিলড্রেন রিসার্চ হসপিটাল ইউএসএ মেমফিসে উনি আছেন। দীর্ঘদিন ওখানে উনি কাজ করছেন ক্লিনিক্যাল ডেটা অ্যানালিস্ট হিসেবে, এবং তাছাড়া ওনার প্রচুর কর্মক্ষেত্রে উনি ছড়িয়ে আছেন। যেমন উনি টাইমস অফ ইন্ডিয়ার ব্র্যান্ড অ্যাম্বাসেডর এবং স্টোরিবোর্ড মেমফিস এবং ডেকান হেরাল্ড নিউজ পেপারের কন্ট্রিবিউটিং অথর। উনি পিকটালে 100 টপ সোশ্যাল গ্লোবাল ইনফ্লুয়েন্সার অ্যাওয়ার্ড পেয়েছেন 2020 সালে, এবং বিভিন্ন রকম ভাবে নানা রকম অ্যাওয়ার্ড এবং তার কর্মের বিস্তৃতি লেখা এবং এই টক শোগুলোকে ভীষণভাবে মানুষের কাছে পৌঁছে দিয়েছেন। আমি আজকের অতিথিকে একটুখানি আলাপ করাতে চাই আপনাদের কাছে। আমাদের অতিথি আজকে ডক্টর ধৃতিমান মৈত্র। তো ডক্টর মৈত্র, নমস্কার এবিএস নিউজ ডেস্ক চ্যানেলের থেকে। ডক্টর মৈত্র অত্যন্ত একজন প্রতিভাবান চিকিৎসক। অল্প কথায় তাকে বলবো, তারপর তার মুখে সব শুনবো। সো ডক্টর মৈত্রর কলকাতা মেডিকেল কলেজের প্রাক্তনী, এবং উনি একটা বিশেষ সাবজেক্টে উনি পারদর্শী বলবো না, মানে উনি অর্জন করেছেন এটা ব্রেস্ট এন্ডোক্রিন অ্যান্ড জেনারেল সার্জারিতে। উনি এমসিএইচ ডিগ্রি করেছেন এইমস নিউ দিল্লি থেকে, এবং প্রথম স্বর্ণপদক প্রাপ্ত ডাক্তার হিসেবে ইতিহাসের পাতায় উনি জায়গা করেছেন। ডক্টর মৈত্রর কিছু কাজকর্ম নিয়ে ওনার মুখেই শুনবো। অরিজিৎ বাসু এবং ডক্টর মৈত্র যখন আলোচনা করবেন আপনারা শুনবেন ওনার বিভিন্ন রকম কীর্তি এবং কিভাবে করেছেন, কি কাজ করছেন উনি, এবং ওনার কাজের ব্যাপ্তিটা অনেক বড়। সো আর সময় নষ্ট করব না, সময়ের একটা বাধা ধরাতে আছে। আপনারা এই শোটা এনজয় করুন, আর আশা করি আপনাদের ভালো লাগবে। ওভার টু অরিজিৎ বাসু।
থ্যাংক ইউ সায়ন বিশ্বাস। সায়নকে এক কথায় পরিচয় করাই। সায়ন is a very talented personality. He is working behind the scenes for me, for making my brand, and he's a brand management heading my all the websites, all the things. And তাছাড়াও সায়নের অনেক কাজ আছে, বিভিন্ন ধরনের ওয়েবসাইট আপনারা হয়তো পরবর্তীকালে which I'll share, যেগুলো has reached several viewership, and অনেক আছে বাংলাতে যেগুলো দুর্গা পূজা নিয়ে ওর যেই সব ওয়েবসাইটগুলো has been watched all over the world. So সায়নকে নিয়ে আমি কথা বলবো, আসবো সায়নের সাথে পরে, বাট আজকে আমার সাথে রয়েছেন ডক্টর ধৃতিমান মৈত্র। সায়ন, thank you once again. We'll bring you up. Dr. Moitra, it's my pleasure and wonderful to have you today in my show, Cross Connection with ARIJIT. And
thank you, ARIJIT. We are alumnus of the same school.
Exactly, and that's my proud feeling. That's such a proud feeling that we are from the same South. We are pointers, and we are proud of our school where we started our journey. And you are very junior to me, and in such a short span of your career, you have achieved wonderful feats, which is incredibly the best I can say. সবাইকে জানিয়ে রাখি, those people who are here today with us, we will converse both in English and Bengali, because few things যেটা coverage করা হয়েছে ওনার ব্যাপারে, few things which has been covered about Dr. Maitra is related to a Bengali movie. I was reading one of the article by one of the news magazines or publication house. They said you are 𝗤𝗏𝗏𝗧 of that Bengali movie, and yes, undoubtedly so. You are one of the 𝗤𝗏𝗏𝗧 for us. AIIMS one of the first. I think I am putting it correctly. You are the first who achieved the gold medal, and for your wonderful work and wonderful feats, and my heartiest congratulations to you. Exactly. এই প্রতিবেদনটা আসার পরে কি মনে হয়েছিল ডক্টর মৈত্র?
অ্যাকচুয়ালি এইমস এ এমএস বা এমডি লেভেলে অনেকে গোল্ড মেডেল পেয়েছে, কিন্তু এমসিএইচ লেভেলে in the subjects which have been started by Department of Surgical Disciplines, সেইগুলোতেই প্রথম এমসিএইচ দেওয়া হলো কারুকে, I mean গোল্ড মেডেল দেওয়া হলো কারুকে। সো প্রথমত তো দ্যাট ওয়াজ আ ভেরি নাইস ফিলিং, অ্যান্ড ইট কেম উইথ ওয়ান্ডারফুল a very wonderful testimonial by my thesis guide and mentor Dr. 𝗦𝗂𝗏𝗏 Srivastava. তো এইগুলো পেয়ে তো I felt very happy. তারপরে আমার back home when I informed everyone, some of my relatives, then my Jamai Babu and all who had friends in the press, news got circulated, and then it came in the newspaper. I didn't contact anyone to kind of get it published or anything, but that somehow came in the newspaper. And the first reaction they gave was when they heard that I'm coming back to Kolkata after procuring the degree or acquiring the degree. তখন I don't know, মানে আমরা I'm from a very middle class family. এবারে middle class family মা বাবারা ছেলে মেয়েদের ডাক্তার করান এই জন্য নয় যে they will earn a lot of money. ওনাদের ক্ষেত্রে প্রথম জিনিসটা থাকে হচ্ছে fame and how you would serve people. হ্যাঁ, এবং আমরা সারা জীবন মানে I have studied on in government hospitals with scholarships. Like I have won scholarships. Those were not kind of government scholarships for the needy, but I got scholarships at all levels. So we had hardly any expense. এই যে আমরা শুনি যে ডাক্তারি পড়তে অনেক খরচ and all that. কিভাবে আমার ডাক্তারি মানে পড়ার পার্টটা I sailed through. মানে so many myths got broken when I actually sailed through my career. I mean MBBS career and then MS. I hardly had to spend anything from my home to become a doctor, first of all. So এবং people from such families who aspire to become doctors, তাদের জন্য এটা একটা ভীষণ বড় মেসেজ যে don't hold yourselves back. In India there are still government hospitals giving very cheap education in the medical field. Please go for it if you aspire to become a doctor, প্রথম কথা। And obviously যারা ধরুন অনেক টাকা খরচা করে প্রাইভেট হসপিটালে পড়ছে তাদের কাছে হয়তো ফার্স্ট প্রায়োরিটি থাকে হাউ টু রিকভার দ্য মানি ব্যাক। আমার কাছে কোনোদিনই সেটা ছিল না, বিকজ আই হ্যাড নো প্রেশার অফ রিকভারিং এনি মানি। সো আমার কাছে আমার মা বাবার যেটা ইচ্ছে ছিল যে ওকে once you are done with everything, come back and at least charity begins at home, at least be of use to your family members, তারপর তো তুমি তোমার বাকি। সো সবকিছু ভেবে and তারপরে আমার এখানে I had a government job to come back to, because I had been sponsored by the government to go to AIIMS and procure this degree. So considering everything, it was a natural choice for me to come back to Kolkata. যখন আমার ডিগ্রিটা শেষ হলো ওখানে there was this COVID thing going on. কিছু কিছু জিনিস ছিল, আমার যিনি মেন্টর ছিলেন উনি বললেন যে I will free you from your service in Kolkata and you just join us here. আমি বললাম না স্যার ঠিক আছে, it's a very, I mean, thank you for your, I will be ever grateful to you for this proposal, but I have to go back to my native place and all. So সেটাই হচ্ছে মানে that's what resonated with the media people, and they started calling me 𝗤𝗏𝗏𝗏 অতটাও কিছু greatness নেই, that's how they put it.
But এটা সূত্র ধরেই আমি বলবো absolutely greatness, because you are too humble. That's what I have seen while I was following you. তার মধ্যে যেটা এন্ডোক্রিন সাবজেক্টটা নিয়ে আমি আসছি, যেটা সবাই অনেকেরই জানা নয়, what is this all about, but তার আগে this rare feat which you have done in just which was circulating in different media channels, newspapers, that the tumor removal of that must have been one of the critical surgery you have conducted in the recent past, and how critical was it, and what are the chances of that case when you
Yes.
took up the case, and now where do we stand with that case?
Yeah. So one day I just come back from hospital when a gentleman came to my house, came to my other house, I mean my old house, and asked my aunt and all whoever he came across whether Dr. Babu is available at home, and they sent him to my present house, which is just across the road. And he was like very kind of depressed and shattered, and he was he complained that his sister is suffering a lot. She's very introvert, and she does not want to talk about it with anyone, but they have realized there's some big tumor in her breast. And the main problem that drew everyone's attention to her problem of the breast tumor was that she was having recurrent episodes of low blood sugar or hypoglycemia. And we all know what happens when patients have hypoglycemic attacks. She would start sweating, she would become cold, somewhat unconscious. Yeah. So they admitted her somewhere and they biopsied the breast lump. And then she said that, 2 months back when she was getting down from a bus or something, somebody hit her there and she started developing the lump, which I don't think is completely true. I think probably the lump was there, but the trauma she had drew her attention to the lump. Okay. And then she said that, the lump grew very fast over the last 2 months. And the biopsy that was done during her admission in the other hospital because of hypoglycemia revealed that this tumor is 𝗲𝗏𝗔's tumor. Now, 𝗲𝗏𝗔's tumor per se is not a very rare finding if you are a breast surgeon. Because the day I operated her, on the very same day, I operated one more case of 𝗲𝗏𝗔's tumor. So for me, who is, kind of getting all the referred cases of breast tumors, 𝗲𝗏𝗔's won't come across as a very rare tumor.
Right.
In my entire career, I may have managed about 35 to 40 cases. But it is definitely much less common than breast carcinoma. The most common tumor, malignant tumor of breast is breast carcinoma. That is far more common, way commoner. This is relatively rare to that. But what was critical about this case was the size, number one. It was, the sheer size of the tumor, it was reaching up to her waist. And the weight. The patient was almost bent forward. She was not being able to stand straight also. Most of the time, she would prefer to lie down. And there were ulcers on the tumor because of, continuous friction. And the recurrent episodes of hypoglycemia. Because in breast tumors, you wouldn't expect hypoglycemia to occur very often.
Okay.
So what I suspected was, she could have another rare tumor in the pancreas, which is called insulinoma. Wow. Those tumors secrete huge amounts of insulin. And we all know what insulin does. It takes down the blood sugar levels.
Right.
So we tested, we subjected her to blood tests like blood insulin level. Then we saw something called connecting peptide, which shows that, whether excessive insulin is being produced in the body, even if the insulin levels are low. And we did an ultrasound and CT scan of her abdomen, but they revealed that there was no problem in the pancreas and there was no insulinoma. Our next suspicion was, since I am trained in endocrine surgery also, I have a background of endocrinology. So my next suspicion was, a similar scenario could occur if the breast tumor itself was secreting a substance which is called insulin-like growth factor 2.
Okay. Mm-hmm.
And finally, after all the blood investigations and all, it was indeed revealed to be secreting, this IGF-2, which was causing hypoglycemia. And my next concern was, after removal of the tumor, whether I will be able to primarily close the skin or there would be an open wound and I would need some other, flaps like chest wall reconstruction.
Or something like that.
Some flap to cover the chest wall. However, after removal of the tumor, I saw that, the skin it was possible to close the skin primarily. So I did not require any complex flaps to reconstruct the chest wall. That way my work got a bit easier. I would say this case was critical in, what I found critical was to be able to diagnose the cause of hypoglycemia associated with this tumor and to tackle this huge, heavy tumor during operation. And the bleeding. These tumors would have excessive development of neovascularization and new blood vessels, and there would be excessive bleeding. But luckily, with our techniques and some advanced instruments, we could ensure that the operation was done without the patient requiring a single unit of blood transfusion, because blood transfusion also has its own downside. And after her operation, within 48 hours, her sugar levels, got normalized. They were back to normal. And within 7 days, we discharged the patient. Later, I removed the sutures also. And the biopsy report that came out, though, such a rapidly growing tumor would generally be a malignant phyllodes tumor, but luckily, it came out to be a benign phyllodes tumor.
Oh, wonderful.
Because phyllodes tumors can be aggressive even if they are benign. And this was that kind of an aggressive but benign phyllodes tumor. So we have kept her on follow-up because these tumors are very notorious for recurrence.
Mm-hmm.
And let's see what happens. As of now, she's doing well.
That's wonderful, because this is such a rare case, and she is improved, and obviously one more question related to that. Like now that you have kept her on a follow-up, so how is she is doing in terms of like keeping up with regular activity? Is she able to do the regular activity?
Yeah. She's back to she's back to a regular day-to-day activity. And the introvert she was before surgery, you should see her now. She's speaking in front of people, speaking in public. She's smiling. She's putting on her lipstick.
Wow, wonderful. So see,
she's out of a depressive phase because she was hiding that tumor under her clothes, like somebody would hide a baby. It was huge.
How long she was hiding that? How many months?
That no one knows.
So that's what I wanted to say to the people, to convey to the people, that everything is possible. Don't be depressed, and there is always a way out if you treat. If you come to the doctor and get checked up and don't keep it until the last date. So now coming back, and this is my best regards to you for doing such a remarkable job. And related to this, right now, this subject which is growing, like the tumor, the endocrine, that's a subject which is the people are not very aware of. So what do you think about this? What should people, very limited knowledge we have on this kind of subject, what people should know?
People, am I audible?
Yes, very much.
People know about branches, when people know about broad specialties, like, this is a doctor of medicine, this is a doctor of surgery, and then they know super specialties which have been, or subspecialties which have been there for ages, like cardiothoracic or cardiology. They know about neurology or neurosurgery. They know about plastic surgery, things like that. Right. But though people know about endocrinology, medical endocrinology, that is, the science of dealing with diabetes, with medical disorders of the thyroid, or calcium metabolism disorders arising of parathyroid problems. The medical endocrinology is still known as a subject to people, though some people may refer to endocrinologists as diabetologists. Endocrinology, the word endocrinology is not very common among the general masses.
Right.
They would refer to endocrinologists as thyroid specialists or diabetologists, like that. Still, medical endocrinology is a well-known branch in spite of this lacuna. However, endocrine surgery is in a very nascent stage, in spite of this subject being there for years. In India, CMC Vellore Sanjay Gandhi Postgraduate Institute in Lucknow, KGMC Lucknow, and Madras Medical College. These 4 hospitals, these 4 colleges only offer MCH endocrine surgery courses. And AIIMS New Delhi offers MCH in breast surgery, endocrine surgery, and general surgery together. So, these 5 institutes are offering courses in endocrine surgery. So, obviously, there aren't many seats. So, too many doctors are not preparing for those seats because there's low chance of getting them, getting selected in those courses. And the general people also do not know the name of this branch because there are less doctors as practicing as specialists or subspecialists or super specialists in that branch. So our endeavor, apart from doing our work, is also to spread the word and spread the awareness about this subject, which deals with surgeries of the thyroid, be it benign conditions like goiters or malignant conditions like papillary carcinoma of thyroid, medullary carcinoma of thyroid, etc. Parathyroid conditions, we know that apart from thyroid, there are 4 parathyroid glands around the thyroid, and when there is any abnormality, when there is increased activity of the parathyroids, there is increased calcium levels in the blood. So anyone having increased calcium should undergo a IPTH, parathormone level testing, to see whether parathormone levels are raised, and then they should undergo surgery for that. So parathyroid diseases, both benign and malignant. Say somebody is forming recurrent kidney stones, so that patient is also likely to be a patient with increased parathormone activity, and that patient is also suggested to undergo parathyroid surgery. But this awareness is not there. Then apart from that, we have these adrenal gland diseases like adrenal cortical diseases like Cushing's syndrome, Conn syndrome, or adrenocortical cancer, and then medullary diseases of adrenal like pheochromocytoma. These are all hormone-secreting tumors of adrenal. In pheochromocytoma, patients have hypertension, palpitations, sweating. Hypertension means increased BP. And then in Cushing's syndrome, there are so many other problems, like patients become diabetic, obese, with hypertension, with characteristic round faces. Even in aldosteronoma, patients develop hypertension. So, a hypertensive patient could have an adrenal tumor that is causing hypertension, and the patient is taking medicines of high BP for years, and they're not diagnosed. So, this awareness is required. Then there are endocrine tumors of the pancreas, like the one I said, insulinoma, glucagonoma, gastrinoma. Somebody having an insulinoma would have increased levels of insulin in the blood, and they will have recurrent episodes of hypoglycemia. Somebody with gastrinoma would have gastrin secreting tumors, means they would have hyperacidity. So many non-specific medical symptoms could be due to endocrine tumors which need surgical treatment. This awareness is not there. Patients would go to surgical oncologists or general surgeons, for treatment of these conditions. They are very well, capable of of treating these conditions. But people should also know that there's a dedicated branch in surgery which is meant for these kind of surgeries. As endocrine surgeons, we are still not doing pituitary surgery. That is still under the purview of neuroendocrine surgery or neurosurgery. And we are trying to get into that area also. And we do a bit of ovarian tumors and, hormone secreting ovarian tumors or testicular tumors as well.
So going back to the breast again, like when do you think that the people, the ladies, or they should get concerned, or rather go to the doctor? What are the kind of symptoms they would witness, and then they should go without waiting, so that they can have a screening testing done, baseline thing going on, then you can have the treatment plans for that. It's always not necessary to have a malignant cases. It can always be a benign ones too, right? So, but the stigma is there that that why do we go to the doctor? I'm fine. But when do you think that they should go?
Benign tumors actually are not a matter of concern, but you wouldn't really know which is benign and which is malignant. You need to go to the doctor for the doctor to tell you that this is a benign tumor, you need not worry about it. For that also you have to go to a doctor. So I would tell you what are the signs and symptoms which should prompt you to meet a doctor. First of all, we suggest that all girls above 20 years of age should do a self breast examination once a month. They should themselves examine their breasts once a month, 7 to 10 days after their menstrual period is over. While they are bathing in the toilet, they can stand in front of the mirror, look at their breasts or feel the breasts for themselves with the flat of their fingers, this area. They can feel the breast against the chest wall like this, to look for any lump, to look for any asymmetry of size on the two sides, to look for any changes in the skin. The skin becomes thick or orange peel-like. Any discharge from the nipple, especially if it is laden with blood. Okay. Any ulcer on the skin, or any asymmetry, like one breast becomes bigger than the other. Things like that. Most of the time, patients will have pain without any other problem. So mastalgia as such is not related with cancer. 80% of patients coming to our breast clinic would have mastalgia, breast pain. So you need not be very worried if it's only breast pain, but when these other symptoms are there, you should go to a doctor.
Yes.
And this self-breast examination should start from 20 years of age. And this is like self-breast examination. Now you find something, some abnormality on self-breast examination, then you go to a local nurse, and the nurse takes you to a doctor if there's something more grave, and then you undergo ultrasound, biopsy, etc. Now, for the population, we say that in the US, Canada, and in the West, more specifically, they've said in some countries it's the screening program involves either yearly or biannual radiological examination with ultrasound and mammography. Some countries say do it with an MRI, but that's not very commonly done everywhere. And in India also, our national program of prevention of non-communicable diseases has now focused on breast cancer, oral cancer, cervical cancer, hypertension, and diabetes. And they are saying that, see, there's a problem with India. The ladies, the women who come to our chambers, you ask them their age, they will point out to their husbands.
Yes, exactly.
He knows, I don't know. And then finally, she will come up with a very, ambiguous, vague age. She will say that she's 35 years old. And you would see her son standing next to her who is 30 years old. So you know very well that this patient is not 35 years old. So there is a misrepresentation of age. A 50-year-old often represents or presents herself as a 30-year-old. So there was this, confusion when we are starting this screening program as to when to start mammographic screening. Tata was saying start from 50, AIMS was saying start from 30, because a lot of ladies would be there who are actually 50, and they're saying they're somewhere between 30 and 50, and we would lose out on those patients. So finally, what the program has been set is, you can start screening from 30 years of age with an ultrasound, but till you reach 35, you do not need to do a mammography. From 35, you can undergo yearly mammography, or say you get a baseline mammography at 35, and then from 40, you undergo yearly mammography to see how you're faring. Okay. So this is an important aspect of screening. And another aspect is there that some families have history of breast cancer. They have already got patients of breast cancer, their mothers, or sometimes what happens is the elder daughter comes with cancer first, and after a few years, the mother comes with cancer. So obviously the elder daughter got the bad genes from the mother, but she became the index case in the family. The mother did not. So, and this paternal-sided cancer history is also important. Paternal aunt, paternal sisters, first-degree relatives. Then uncles having colorectal cancer or a very high-grade metastatic prostate cancer. These also point towards genetic high risk of cancer. In such families, you have to start screening the patient with imaging 10 years prior to the first, in that family, suppose a lady got diagnosed with cancer at 35. So all the other ladies should start undergo screening from 25, which is 10 years prior to the lowest age of presentation of cancer in the family. And now if the lady is 25, obviously you're starting this imaging screening on that lady, but mammography is not suitable.
Right.
unless the lady is more than 35. So in that lady who is 25, and in her family there has been a cancer patient of 30, age 30, 32 years, you have to start screening at that young age. But what is your tool of screening? You have to either do ultrasound or MRI. So that therein comes the role of MRI. Or somebody who has undergone radiation.
Right.
Young girls, they suffer from lymphoma or leukemia. They have been subjected to radiation maybe. So, in those girls, you have to start screening them a bit early because radiation is a risk factor for breast cancer. Again, somebody having a cancer on one breast herself should be careful about her other breast.
Other breast.
Or a lady who has been detected with ovarian cancer herself at a very young age, that lady could be carrying the bad genes for breast cancer as well. Because this BRCA1 mutation, which we already know was there in the family of Angelina Jolie, for which she underwent,
right.
surgery, risk-reducing surgery. So that could be there in the lady. So these are certain things which should point, who are at higher risk of getting cancer and who should be screened at a younger age, and what should be the, normal age of starting screening. So this, was kind of an overview of that.
I was reading the research studies says the success rate in nowadays is quite high. It's close to around 80%. So is that fact?
Yes, because in the West, most of the patients are diagnosed to be having cancers on screening. So, they are coming for screening. You detect a cancer which is not yet palpable. You are not being able to palpate it with your hand. It is so small. It is detected by virtue of screening only. It was detected only because you underwent that imaging. Right. If you would have waited for symptoms to arise and then you would have undergone an imaging, then the tumor would have progressed already. So when you are detecting tumors by screening at such an early stage, you are in all probability detecting tumors which have not metastasized. And any tumor which has not metastasized has a very good prognosis. And, the later the disease is detected, the bigger is the surgery, the more mutilating is the surgery. You have to remove breasts in some cases if they're presenting with advanced cancer, whereas in early breast cancer, you can conserve their breasts. You can do a more conservative surgery. Then there's sometimes if it's in a very early stage, then there's no need of chemotherapy as well. So there are certain advantages of detecting cancers early and treating them early, which screening, good screening programs are giving us now.
Okay.
So that way results of treatment are improving, and also because we have more sophisticated radiation techniques and chemotherapeutic agents nowadays which have less deleterious effects, which makes the treatment outcomes even better with less side effects.
Right. Absolutely.
So there's an all-round advancement in everything, detection of diseases early, treating them, starting
more
the treatment early.
I think sorry to interrupt you.
As well as advanced technology in chemotherapy, radiotherapy, and surgery, which is making the outcomes better and better every day. And now the outcomes are so good that nobody now asks this question, how long am I going to live? Counting the years is no more a matter of concern as far as early breast cancer is concerned. People are coming with cosmetic concerns now, whether my breast will look good after surgery or not. And therein comes the importance of oncoplastic breast surgery. So we are doing,
so the people are
kind of surgery called oncoplastic breast surgery for early breast cancer patients. That's with the sole purpose of giving them not just adding years to their lives, but giving them meaningful years, a very good positive body image. So they don't just we are not prolonging death. We are actually increasing the lifespan of the patient, meaningful lifespan of the patient. We are not just leaving behind a mound for mount's sake on the chest wall, but something which is aesthetically pleasing to the patients as well.
Right. Now that we have been talking to you for almost half an hour, before we end this show, I would have liked to continue this show for hours and hours, because I have so many questions which I think I could have asked, but there is always a time constraint, and always many things we should know as we go. So, but before that, I want to just ask one more question. Now that you are into a person doing his this getting a gold medal and studying in IIMs, coming back to Kolkata, and now mentoring younger generations. So how does that feel for you?
It's a good feeling, I see a lot of my colleagues who have, got their degrees and then got back to private practice. Private practice definitely is allowed in our state. That's a great thing that, side by side, besides teaching in government hospitals, you can still pursue private practice. That's a great thing. It gives us the best of two worlds, both the worlds. Private practice is needed definitely to, increase your public image and, to reach out to more people, a higher strata of people, because you wouldn't have that, you have a different group of patients coming to the government hospitals and to the private hospitals.
Right.
So,
Dr. Mayitra, are we
when you are
getting
there,
the right
both,
kind of people? Are we
and when you
getting
are there with both the setups, you can reach out to more people. And the added advantage of being in the government hospital is being able, it empowers you to be able to reach out with your surgical skills to your students and juniors who are actually observing your skills and incorporating whatever they want to in their way of surgery. And they see 2-3 surgeons operating, and then they deduce their own method of surgery, what they think is best. So this contribution to create the next generation of surgeons definitely makes me feel more complete.
Yes, absolutely. You're very true. And doctors like you is mostly needed in our country, in our states, so that we can make more better future, create more new young generations who can lead us further and make more inventions. And thanks to you, and we and for my viewers, just to let you know that not only does Dr. Mayitra does all this, he has also helped many frontline workers during the time of COVID with his many unique approaches, which because of the time constraint, I will not be able to put it right now. But yes, he is doing a terrible, wonderful job, and my sincere gratitude to you for giving your best to the community, to the society, and keep doing good, Dr. Mayitra. My best to you always. And yeah, Namaskar.
Thank you, Arijita. It was lovely talking to you. I felt extremely honored with all your kind words and everything, and it was a real honor to be talking to you. Since it's the beginning of the day for you in the US, so have a great day.
You too. Have a good night. And I
Yeah,
know
thank
you keep so busy and with so many things, but finding time out for me, it's yes, an honor for me too. Thank you.
Thanks a lot. Thanks for having me. Thank
Thank
you.
you.
Signing off.
For all my viewers, Arijit Basu from AB's News Desk. Good morning, good evening, good night, wherever you are. Keep watching my shows. I will be coming up with one more person who is multifaceted in the next week, and he is a CEO of one of the investment firm, and he is also own a cafe shop in Jodhpur Park in Kolkata, and he was a journalist before. And he is now also, apart from all this, he's also covering many investment related articles in all the newspapers. So he's highly rated. I am coming up with him next week. Thank you. Until then, keep watching, keep following, share the page, share my page, and until then, goodbye to you all.
Goodbye.
And thank you, Shayan, for starting the show. I would like to bring you once again, again and again. Thank you for all that you do for me.